Thank you very much to Tips and Training for the invitation to speak this evening. It's been a strange old few months, and as you can tell from the slide in front of you, I've got the date on there wrong because I have no idea what day of the week it is at the moment at all. We're actually back at work today, and today's my first endo I've done for the last nearly 4 months now, and I'm going to show it you later on. I'm not somebody that likes to present just my best cases. I like to present what I do on a daily basis. So a little bit of background. I am a practitioner limited to endodontics in referral practice in Sheffield. I've been doing endodontics only now for 15 years plus, had a microscope for the best part of 20 years. And the slide you have in front of you there is of the harbour in San Diego, which is where I've received my microscope training under the Pacific Endodontic Research Foundation. And a lot of my best education comes from meetings held by that organization every year. So tonight I've been asked to talk about root canal obturation. I was originally going to talk just about the new bioceramic sealers, but I've been asked to talk about what was described as modern endodontic obturation techniques. So I think to enable me to do that, I need to define obturation first of all and why we do it. And things on the slides in the next 2 or 3 slides will be a little bit rich in text, but after that we're going to have a lot of images. And I'm going to tell you what I do on a daily basis. I'm going to tell you what materials I use. I'm going to tell you what equipment I use with those materials and why I use those materials backed with science and evidence. And I'm going to show you how I use those materials and when I'm going to choose different materials. I do a lot of teaching hands-on wise around the world, and maybe my definition of modern is different to other people's definitions of modern. So I know in the UK, we are still teaching in dental school undergraduate level lateral condensation, cold lateral condensation. I can honestly say I haven't done cold lateral condensation for over 25 years. So to me, cold lateral condensation is not a modern technique. I don't know any endodontists that use cold lateral condensation. So it's not something I'm going to talk about tonight. For me, modern is warm vertical condensation techniques with hydraulics in there, and maybe using different types of sealers. And I'm going to go through a little bit of history of those as well, as to when they became researched and when they became published, when we started to hear about them in the UK, and then when they became more commonplace, and maybe even my own personal thoughts as to why things aren't taught as much in the UK undergraduate schools. It may be different in some schools. I don't have experience of all the schools, as to why we don't teach warm vertical everywhere. So my biggest mentor is Gary Carr, who is the grandfather basically of microscopes in dentistry, the first person really to start to use a scope in dentistry. And Gary's written a couple of chapters in this textbook. It's a fantastic book for practical endodontics. It's published by Quintessence. It's called Best Practices in Endodontics. There is a chapter in there about obturation as well. It's absolutely jam-packed with clinical hints and tips from some really, really fantastic clinicians from all the way around the world. And I'd recommend to try and get hold of a copy of that before it goes out of print. If you have an interest in endodontics, it will really help you out in your general practice on a day-to-day basis. So what's the goal of endodontic obturation? So this is from Gunnar Bergenholtz's textbook here, Textbook of Endodontology. We want to classically stop coronal leakage, entomb bacteria, because we know we can't remove all bacteria from within inside a root canal system. So we want to prevent those giving us problems later on down the line. We want to stop an influx of periradicular fluids and prevent release of bacterial elements back into the tissues. So we need to be sealing really at both ends of the root canal system. In the past, it was thought that we could do this purely with a sealer. That isn't the case anymore. A sealer on its own has too much leakage, too much shrinkage, and we need gutta percha in there or some form of other material to help take up the space and have the sealer in as thinner section as possible. So from a recent article by, this is Marcus Hapasalo, ideal properties of root canal obturation materials. The materials should be easy to use, visible on a radiograph, biocompatible, bioactive, have antimicrobial property, resorbable in tissues, resist resorption within tooth structure, etc., etc. An important one there later on is be easy to replace. My practice is probably 60 to 70% retreatment cases. So I need to know whether I can remove root filling materials from inside root canals, because if I can't, my success rates in retreatment are diminished. Visible on the radiograph is really important. We have newer materials that came into the world over the last 20 years, maybe. I was involved in some pre-production trials of some of those materials, and they actually weren't radio-opaque. So I filled up root canals on a patient. I took a radiograph and it looked like I hadn't filled the root canals. So I had to be concerned about what happens if that patient sees another dentist in the future. So I had to retreat my own case because the material hadn't had a radiopacifier added to it. So we need to be really careful with new materials. You'll see when I list materials shortly that some of the materials I talk about have now been removed from the market. So I'm still very wary sometimes of newer materials. I want evidence that they are better than what we already have, because what we already have in gutta percha and conventional sealers has worked really, really well for a long, long time. Some of the newer materials are maybe easier to use, a little bit less complex if you aren't doing a lot of endo, and there's less investment in technology and materials needed in some of the newer materials, and I will talk about those in the last 20 minutes or so of the presentation today. So gutta percha is still the dominating material. The root canal sealers fill the voids that are left around the cones that are placed in the canals. And now with more minimalistic preparations, which are becoming en vogue for the last 10, 15 years, maybe even more if you look at some of Buchanan's early work in the 1990s, we have better materials maybe to fill these smaller shapes than having to use purely thermal techniques. So that's what I'm going to talk about in the last 20 minutes or so of the presentation. So classically, the materials that we've got available to us, some of the older people may remember endomethasone. That's certainly what was en vogue in general practice when I qualified back in 1990, a paste material used without gutta percha, sometimes with gutta percha, but can be used purely as a paste. It's easy to retreat. It's not something we'd recommend now because of toxicity concerns as well. Another one that we see, and I see this reasonably often, is called resin cornol. It's colloquially called Russian red, and that's an acrylic material that's spun into root canals, and it sets very, very hard, really difficult to remove. We need to break that out with ultrasonics, etc. If you've ever seen a tooth filled with Russian red, you'll know about it because the whole tooth stains red. And it's certainly not something I would be encouraging you to treat in general practice without a microscope and knowledge of ultrasonics, etc. Semi-solid materials to take up the majority of the root filling are gutta percha. I'm not going to go into the chemistry of gutta percha tonight. It's 8 o'clock on a Tuesday night. You don't want to be hearing that. You can look it all up. Or solid materials, so silver points. They're still, I'm seeing cases still with silver points. Kish Gulabhavala at the Eastman and Paula NG did a meta-analysis study of outcomes in endodontics of the literature. And in their study, the most successful materials were silver points. Now, I don't think that's to do with the silver point itself. I think it's to do with maybe the tooth having been prepared less. Hence, a silver point was placed in there because a gutta percha cone wouldn't fit. So we've kept more tooth, which I think is probably one of the most important things in endodontics as far as longevity is concerned. So it's maybe not the silver point on its own, and I certainly wouldn't recommend people obturating with silver points now I just want to put it in there as a material that you may see. I retreat silver point cases probably every month. We've done hundreds over the years, so we see a lot of those. MTA, mineral trioxide aggregate, I'll talk about that later. There are people advocating completely filling certain root canal types with mineral trioxide aggregate, and I do that as well. But it's a last resort. It's virtually unretreatable. So it's going to be in retreatment cases, in really wide open apex cases, that we're going to use MTA as a material of last resort. Bioceramics, MTA was a bioceramic, is a bioceramics, and a lot of the research about bioceramics comes from the original MTA research. I'll talk about those in more detail later on. There's specifically now bioceramics being made as a root canal sealer. They're all basically made by the same company, originally patents put out there in Vancouver. So we'll talk about that later on with iRoot SP and the different types of sealers that are out there. Sealers themselves, I'm going to talk about a couple of different ones. I personally use a zinc oxide-based sealer for my gutta percha work with heat because it's been around a long time. I'll talk about it in a little bit more detail later on. The other sealer that most endodontists that I know will also use is AH+, an acrylic epoxy-based sealer. I've put some other ones on here as well. The resin-based sealer Epiphany was with Resilon. That's now been withdrawn from the market because that had problems 10 years later on down the line. EndoRes is still out there as a sealer from Ultradent. Smart Seal has gone from the market, I believe. Gutterflow is a silicon-based sealant, and we also had some glass ionomer-based sealants years ago. We had Keitac Endo. Again, I'm wary of new products. I'm wary of things that claim to be so much better than something else, and I'm very wary about things I can't retreat. So glass ionomer is really hard to get out of root canals. Resin-based sealers are more difficult to get out of root canals than something that I can dissolve with solvents or remove mechanically. So for me, retreatability is pretty important. Nothing we do lasts forever, and I need to retreat my own cases now and again, and I want to be sure that I can get my old root filling materials out of the canal without removing tooth tissue and weakening the tooth appreciably. So that's a concern to me in materials that I use. And I'm going to talk about how I exactly use my sealer and how we go about placing that, filling the canals, etc. I'm not able to see any questions at the moment, I'm afraid, on the screen. Hopefully, I will answer all your questions in what I'm going to talk about. I usually do when I'm doing these talks. I can have a look through at the end, but I just want to make sure you've got a stable connection, that the screen's working okay for you at the moment. So this is the kind of result that we're getting here, a 3-canal premolar with trifurcation down there. This is kind of routine stuff for us. I don't want to put lots of pictures up of my endo because everybody can pick their own really nice cases and show them. What I want to be able to do is to make you think about, does a nice radiographic appearance correlate with success? Because we've all seen lousy looking root fillings that are perfectly okay. They've been there 30 years. The patient's very happy with them. Is there a reason to go in and replace them because they look lousy on the radiograph? I don't think so. I'm very much somebody that's interested in what I call patient-centered outcomes. So if we have a tooth that's comfortable, the patient can bite on, the patient can function, just because it looks lousy on a radiograph, what am I going to make better for that patient by going in and retreating it? Nothing. So yes, there is a correlation between radiographic appearance and radiographic technical quality and outcome. So we will strive always for the best outcome and the best radiographic appearance. But if we sometimes are maybe 2-3 millimeters short, I don't think we automatically need to go in and start redoing things in the absence of symptoms. In the presence of symptoms, it's a different conversation. So I'm going to show you 3-dimensional obturation. We're very much, these are some old slides of Cliff Ruddle's on the animations, the clinical cases, one of my cases. That would have been a pro-taper case, and I know how long ago it is because I've got a recall picture coming up. So you can see there that we've cleaned shaped and filled in the apical 2-3 millimeters. We've got irrigant down there, or else we wouldn't have been able to clean out the necrotic tissue from that little apical lateral canal, and then we're able to force gutta perca and sealer into that area to prevent re-ingress of bacteria. And I think that case, the reason I show that case is to try and mimic the diagram there. We've got fabulous 3D printed teeth now that we can do this on in the hands-on stage of things when we run the courses, and they show really, really well how we go about obturating in 3 dimensions with our heated techniques. And then this is a 12-year recall of that case. So these are holding up with time. This 12-year recall was from about 3 years ago. I've not needed to take another film since then, but we know that the patient's going along pretty successfully with that tooth. So I mentioned earlier about modern techniques, and warm vertical condensation comes from the work of Herb Schilder from Boston University, and this was described back in 1967. Warm vertical condensation was being described back as far as 1967. I'll put a link on the last slide to a website where you can download these papers as well, because I really think if you do have an interest in endo, these are the gold standard of papers. The reason the left-hand paper is there, that's from the JOE in 2006. It was actually a tribute to Herb Schilder that they republished his original articles because they were of such importance. That doesn't happen very often. So Ken Hargreaves, the editor of the JOE, republished this somewhat either 30, 40 years after the original article. And then the other article is really, really worth reading. It's from a textbook, but the full article is available on the website that I will show you later on. And it really gives a really good understanding of warm vertical techniques if it's not something you've been exposed to and if it's not something you are familiar with. So why do we want to do warm vertical as opposed to cold lateral condensation? Well, for me, it's easier. Is one thing. I use less gutta perca cones, but the studies will show us as well that gutta perca warm vertical compaction had the best seal with bacterial leakage observed in only 16.7% of the specimens, whereas the other specimens in this study, this was done with single cones with gutta perca with warm vertical and then with cold lateral, and the warm vertical had a lot less leakage of other cases. The other cases were AH plus and sealer, and the conclusion is gutta perca and AH plus was more effective in minimizing bacterial leakage when done with warm vertical condensation. Similar paper here indicating microbial leakage more quickly with lateral condensation than with system B continuous wave of condensation. I'm going to explain what system B is and what continuous wave of condensation means as we go on through this. To me, it's just easier if we have the right materials and the right equipment to be able to do this with. If you are using a heated Bunsen burner and a hot instrument, which I'm still hearing people are doing, I don't think we should be doing that anymore. I did that back in the early 1990s, but we've no need to do that. We have much better equipment, much safer, much more controllable equipment now to enable us to do this predictably, quickly, safely, and give us a better obturation for the patient. So these are the instruments that are out there. People may be familiar with System B on the left-hand side and the Obtura gun on the right-hand side. So these are old slides. I bought a System B when I was an associate in 1995. I still have it. It still works. I've now gone on to a cordless system because I very much prefer cordless instruments when I can. They work much, much easier with the microscope and the way that I work in four-handed microscope dentistry than instruments with cords. But I have my System B as a backup. And the Obtura, if you haven't seen an Obtura, that's an injectable pellet of gutta perca that's warmed up inside this little gun, injected down a silver needle, and fills what we call the backfill part of the root canal after we finish our initial down pack. I'm going to show some animations of these, I'm going to show some videos of these so you'll be able to see what it looks like in practice. Normally I'd be doing a demo of this down the scope in front of people, but it's a bit impractical to bring a microscope home with us. This is a derivation of that unit. This is called the Elements Obturation Unit, and this is on the one side of the unit is the System B and the other side is the obturer. It's more mechanized. I had one of these and I found it really quite complex. I found there were far too many buttons to press on there. I never knew what it was doing. This must be, we're trying to think, 10, 15 years ago. And I was mentioning to the manufacturer then, can you simplify this? Can you make it easier? And can you make it cordless, please? And they did. So Steve Buchanan, well-known endodontist in Santa Barbara, works with Cavo Kerr, who sell this in the UK, and it's now a cordless device. So Buchanan shares my view that cords are getting in the way, especially now with the precautions we need to be taking with barriers, etc. The more we can avoid cords, the better. These are really easy to wipe down. The tips are autoclavable. The backfill part of it are disposable, so we don't have cross-infection control concerns. Anybody that's maybe used an obturer gun or the B&L Beta or the Hot Shots, various different generations of those, will know that they get pretty warm and they have a heat shield on them to prevent burning the patient. The Elements Obturation Unit doesn't need that. It doesn't get as warm. It's got a really good way of protecting you, the operator, so you can hold this just with a gloved hand without a problem because of a heat shield that's inside there, and it doesn't burn the patient. And these images are pretty striking, really. So we've got the Elements Free on the left, then we've got the B&L, the Calamus, which is a Dentsply corded unit, and then we've got the Obturer, which is also a corded unit. I'm going to show you another unit that I've used from Dentsply, which is cordless, which again, really, really nice. Really like that unit. I used it over in Abu Dhabi a few months ago, giving a hands-on course over there. The delegates really, really liked it. So I think that's certainly a unit to consider. Little bit of video coming up now. I'm going to just try and describe what's happening on this video as we go through. So this is the Elements Free unit. This has now been superseded by one with induction charging. The features are pretty much the same, but improved. So this is the System B part of things. We've got a lot less buttons. We've basically got on and off and set the temperature. You set the temperature once, and I set this at 200 degrees. My assistant will turn the machine on and off for power, and then to activate it, we press this little ring and it goes blue and it makes a noise, heats it to 200 degrees C in half a second, and when we take our finger off, it cools really, really quickly. So it's going to cool within a matter of seconds, and then it's totally safe. So we heat this in the tooth. We don't have it activated outside the tooth, it's heated in the tooth. The other unit is the injectable unit. This works with a little motor inside here, which is really, really nice as it drives a piston up into soft gutta perca, so we don't have to squeeze the trigger like we used to have to do on an obturer gun. It prevents hand fatigue. Press the little blue button again, and gutta perca will squirt out of the end of the needle here. It's a silver needle that's bendable. You'll see on the video later, there you go, you can see the gutta perca coming out of there. Really nice to use. If you haven't used those before, see if somebody can come and give you a demo, etc. They're really, really nice to use. One button will turn them both on. So as we're mixing our sealer, my assistant will turn this on. It then starts the heating process inside the backfill unit so that we don't have to wait. And it's really seamless. We're filling molars in under 5 minutes easily with this. Excuse me. So again, just a summary of what's on the machine there. It has been simplified a lot. I touch nothing on this at all other than the button to make the material come out of it. That's it. Or the activation button on the System B part of things. You have a preference for maybe having your gutta perca a little bit more fluid. You can change the temperature and increase the temperature. If you want it a little bit stiffer, you can set the temperature down as well. They're both fitting either side of it. They fit the original System B tips. So if you have a system B from 20 years ago, you can still fit the same tips in there. If you have the original Elements obturation unit, non-cordless, you can still fit the same cartridges in there. So that's nice that we've not got to throw things away that we've invested in previously. And this is the latest generation of that. This is the Elements IC for inductive charging. So it's got a capacitor in there rather than a battery. Little bit faster to warm up, a little bit faster to extrude the material, slightly smaller needle, enables better penetration into the root canals. So if you're buying this particular brand of product now, this is the one to be looking at. There's also Dentsply's product, which is really, really nice. I would have no issues at all in using this in practice. The Gutter Smart cordless obturation unit. This one, you set your temperatures, etc., on the touchscreen, and then similar activation, etc., on the unit itself. I was teaching this to 30 dentists who'd never used any heated systems before, and they all managed to use this really, really well after kind of half a day's tuition. So it worked really, really nicely. Similar base station, cordless, stays charged for long enough, multi-surgery practice. You can swap this out between surgeries. You need one base station and then take them to another room if you need to do. You don't need maybe multiple units for different rooms. And it's just the same type of technology. So I'm going to run through exactly what we do with these in terms of how we use them as we progress through here now. So what we don't want to do, and people maybe get afraid of, is things like this, is errors, is overfills, overextensions, putting material into anatomical structures. There's a question mark on the other tooth, but why on earth did he put gutter perca in that tooth there? Neither of these are my cases, thankfully. The upper lateral case, I always question when I present this, is it really worth having treated that tooth with how big that post is, how little tooth is left, how long is that likely to last restoratively? That's a big concern to me. Even as an endodontist, I have big concerns about restorative failure later on. More teeth fail from restorative than they do from endo. So certainly if that tooth came to me now there, I wouldn't be recommending treating other than extraction of that tooth. So we need to be careful in our canal preparation, and we need to be careful in our working length measurement as well. So I haven't really got time this evening to go through preparation in a long way, but basically if we have a nice tapered canal preparation, which our modern files give us, so our rotary nickel titanium file, whatever brand you're using, is going to produce a tapered canal shape in most teeth. In retreatment cases, it may be different because we may have lost anatomy from previous treatment. If we have a tapered shape and we heat this and push down on it, we don't have extrusion. We have a little bit of lateral force put into our material. So that's what's called the down pack. That's with the system B part of things. And then we leave that space. If we're placing a post, we're done. If we need to backfill, that's when we use the injectable part of things now. Hopefully that makes sense. If we have parallel sides and we have no resistance form, and then we press on this, only one thing's going to happen, and that is that gutter perca or whatever material we have is going to be pushed through the apex. So that's not a suitable anatomy to be using a warm vertical obturation technique. In a large open apex like that, I alluded to it earlier, I'm going to use MTA as my apical filling material. Really biocompatible, a little bit difficult to work with, which I'll touch on later, but anything where I've apically gauged bigger than maybe a size 60 ISO file, I'm not going to use one vertical because I can't have control of that material apically, and the best seal that I'm going to get is with MTA, and the best biocompatible result I'm going to get is with MTA. Big open apex cases like this are last resort cases, so I don't have a problem using a non-retrievable material because the alternative is extraction. So I talked about measuring working length. This is the last thing I do after I've used my apex locator, etc. I don't always take a working length film. I use an apex locator religiously, and then I'm going to do a technique called the paper point technique to confirm my working length at the end of the procedure when I've finished all my irrigation. So this is a cross section through a end of a root of a tooth here, the black line being the cemento enamel junction, the brown bit being inside the root of the tooth, the white bit being the apical cementum there. And if we take a paper point, having achieved patency, and put that through the end of the root of the tooth, we're going to have fluid on that. It may not necessarily be blood, but we're going to have fluid on that. All that indicates is that that paper point has gone through the end of the root of the tooth. It doesn't tell us how long that root canal is. We know it's gone long. So if we get a paper point that stays inside the root canal, we know it's in the root canal because it's not got fluid on there. And what we need to do is keep repeating this until we find this consistent, wet, dry point with the paper point. So it's not how far the fluid comes up the paper point, it's when that first, bit like using a dipstick in your car, when you first go through the end of the root of the tooth, that confirms your working length. And then I'm going to fit my gutta-percha cone short of that by maybe 0.5 to 1 millimeter, because I know that in one vertical I'm going to move it a little bit. So I fit my cone at about 1 millimeter short of my paper point working length, which should correspond to your zero length with your apex locator. So that point there is where is zero, and then I take 1 millimeter of that and I fit my cone. I'm going to explain what fitting a cone means and what instruments to use for that and what cones to use as well. So most of your root canal file systems will have matched gutta-percha of a greater taper, and I'm quite interested to try the new dense ply gutta-percha because that's quite unique in that it's not hand rolled like most gutta-percha is, it's injection molded. The reason I want to try it is because we'll all have had the problem of 3 sticks of gutta-percha that say they're a 2506 are all different because they're hand rolled. And some of them have got a size 25 at the tip, the next one's a size 30 at the tip, the next one's a size 20. There's more consistency in the injection molded points. So I'm looking forward to, now that we're back at work, being able to get some of those and try some of those rather than constantly be fitting my cones myself. So the cones are made to fit the shape of your root canal files, and we need an awful lot less than standard O2 taper, old-fashioned master cones, as I was taught back in the 1980s. So I'm going to use maybe an 08 cone to match an 08 file. So I'm going to tip size 25, 08. If I need a bigger tip, then I'm going to use instruments to help me do that, and I'll show you how we do that later on. That's called tip trimming. This is when I'm trying my gutta-percha cones into the root canal. In a wet root canal, I try them in sodium hypochlorite. That helps move the sodium hypochlorite around inside the root canals to activate the irrigant. It disinfects my gutta-percha cone, and it mimics the effect of the lubricant on the sealer. If we try in dry root canals, we're going to fit our cone short. So I always try in a wet root canal. So these are the Gutta Smart cones that I was talking about, the ones from dense ply. And as you can see there, they're used to match the shape of a canal, prepared using their files. You can mix and match brands and manufacturers without issue. It really isn't a problem. When I give courses around the world, we don't always have the same brands and manufacturers, etc. But we can learn how to fit a cone. So one manufacturer's 2506 may fit somebody's 2508 file better, and you'll get to learn this yourself. But these claim to produce a shape and fit 40% more accurate than hand roll gutta-percha, which is going to be a good thing. So as I say, I'm quite looking forward to getting some of those and trying some of those out. So what does it actually mean? What do we do? I'm going to run through this 2 or 3 times in case people haven't seen this before. We fit our cone. And for me, that means 1 millimeter short of apex locator 0, millimeter short of our paper point working length. And we're doing that in a wet root canal full of sodium hypochlorite. Then we fit our vertical plugger. I'm going to show you what pluggers to use later. We want our plugger not to be binding on the walls of the root canal. If we press onto walls of root canal, we risk breaking the tooth. we only ever press into the gutta-percha material. So we fit that with a silicone stop on the reference point, and we always stop short of that silicone stop. We heat our gadget to 200 degrees C, and we maintain pressure for about 2 to 3 seconds as we've got heat applied. That then makes our plugger sink down towards that binding point. Then we take our finger off the heat, and then we press on that apical part for 10 seconds whilst it cools. We're maintaining apical condensation pressure whilst that apical part is cooling to prevent shrinkage. Then we apply a bit more heat, so what's called a separation burst. We do that for about 1 second. That helps stop our plugger and gutta-percha coming out together. So we want to leave that apical 5-6 millimeters of gutta-percha in place. It applies heat really quickly to this area, separates the two, pull the plugger out, twist and remove. And I say on an anterior tooth, if we want to place a post, we're done at that stage. On a posterior tooth, then we go in with the injectable system to fill the void that we've created with our plugger. What does that look like? We'll just run through the same kind of video animations again, then I'll show a video. So we know root canals are complex. System B, we can use this with the different tips that are standardized. So the tips have the tapers to match your files, that match the gutta-percha, that match the paper points. So everything's designed for the purpose. So this is the same again. Choose this plugger, place a rubber stop on the plugger so that we don't have metal on tooth contact. Adjust the stop to the reference point. They're bendable, the pluggers. You'll see that in the video, how we can bend these. Dry the canal, cut the gutta-percha, put some sealer on your cone, 200 degrees C. Press down for 2 to 3 seconds, and then keep plugger pressure on for 10 seconds at the end. So we've gone to within 3 to 4 millimeters of the binding point. Downpack takes 1.5 to 3.5 seconds. And then we keep this sustained push for 10 seconds to prevent apical cooling and shrinkage. The next thing we do is what's called a separation burst, which is the 1 second to leave that mass of gutta-percha apically, pull that out, leave the coronal part. And if, as it says there, if you need a post space, you're done. If not, we inject with the obturer. So it looks like this. So the video here says 1/2 mil short. I'm going to go 1 mil short. We can bend the pluggers to follow the curve so that we get the plugger within, ideally within 6 millimeters of the apex. There's your reference point. So you're not going to bind by knowing that if you stop short of that silicone stop, you're fine. Little bit of sealer on the cone. You really don't need a great deal of sealer. Use the System B. Tap it down with your little Dovgan, Buchanan, mash tube plugger, whichever one you have. Place your System B, turn it on, 3 seconds, push, 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 push. Take the heat off now and press for 10 seconds. He says 5. The technique is designed to be used for 10 seconds. And then your separation burst, and then out it comes. So you deliberately take out this coronal part, the apical part's still there. If you want to replug with one of these flexible nickel titanium pluggers, you can do. I don't often do that. Then this is the injectable part. I put sealer on my needle here to help prevent a void. I then leave this 5 seconds to let the temperature stabilize. And then I inject and just let this back yourself out of the root canal. You can see how that works there, yeah? Backing yourself out of the root canal. Bang, done. Take another big plugger now, plug the coronal part, done. So it takes some practice. And when I first started doing this, I did a lot of extracted teeth, a lot of plastic blocks. I pulled a lot of gutta-percha out initially. It is technique sensitive, and if you aren't doing a lot of endo, then there may be alternatives that are easier to do. But this is still my go-to technique on a day-to-day basis, and also that which nearly every endodontist I know does on a day-to-day basis. So this is my sealer that I use. I'm not saying it's the best, it just is the one that I use. It's Kerr's Pulp Canal Sealer. EWT for extended working time. It's a zinc oxide eugenol sealer. It works well in heat. It's got a lot of data behind it. It's got 70 years probably now of usage. It's not going to be something that suddenly starts to give us problems 10 years later because it's been around for long enough. So for me, it's biocompatible. It resorbs outside of the tooth, but it doesn't resorb inside the tooth. It inhibits prostaglandin synthesis, so that's less after pain as well. We can use a minimal amount, a thin layer, so we've less of it to wash out. I talked initially about sealer filling the spaces around the gutta-perca, and the more gutta-perca we can have, the better. The other reason I like the zinc oxide eugenol-based sealer is that the major constituent of the gutta-perca cone is zinc oxide eugenol. So when I heat my cone up and I heat my sealer with it, I'm making a homogeneous mass of the same material. So I've got one material, which is basically zinc oxide eugenol in there to fill my root canals up with. Again, I do know a lot of people that use AH+, and it comes out really, really well in the literature. So I'd be happy to use that as well. It's a nice material to use. Works well with the heated techniques also. Pluggers. There's many of these around. These are Buchanan pluggers from Cybron Endo. If you go on QED, Quality Endodontic Distributors website, you'll see some MASH 2 pluggers from Dentsply, and then Miltex, a company in the US, sell Dovgan pluggers, which were a really nice plugger. Stainless steel at the fat end, nickel titanium at the thin end, designed to fill and plug as many different anatomical shapes as needed. I talked a little bit about customizing our cones. So if we have maybe a size 25 cone and we want to make it to a 40, there's a gadget here from Cybron called a tip snip, which you can put it through the size 40 hole. It's got a little blade, that little brass cutter that you see there that chops the end of it off. I use this instead. I use what's called a tape plate. This is from EIE2.com. And as you can see here, it's got a few more different sizes to go at. So it's in kind of quarter sizes going up there. You poke your gutta-perca through the hole, you take a scalpel blade on the other side, and my assistant will chop off with a scalpel blade. So we've got all these pre-sized in advance. From my typical sizes go from a size 20, maybe to a size 35. And I'm going to have all those pre-sized in the different tapers. So we don't have to do this whilst we're working. If we did need to do it whilst we're working, it's no issue. But I like to be ahead of myself and get all this set up in advance. So hopefully that quickly explains what custom fitting your cone is about. And the taper plate to me is the best instrument for that. A little animation for 2 or 3 minutes or so to show. Same sort of thing again, when I think if this is new to people, the more I can reinforce this, the better. And then I'll show a clinical case, and then I will move on to the bioceramics. So this is just the same that we've been talking about. Fit your cone a millimeter short. Turn your machine on, whichever machine you've got. It's the same technique, whether it's the Cybron machine, whether it's the Dentsply machine. There's other machines out there on eBay, etc., that are copies of these. I haven't used those, but they are out there. But these are by far the best way to do this. Size your plugger so that you aren't going to be fracturing the root by pressing onto root. So you will come 2 millimeters short of the binding point there, so you can't possibly press onto the root. And we want that to be, from the fluid dynamics, about 6 mils short of the apex. There is literature to show us how far we can move softened gutta-perca from the end of a root of a tooth, and it goes from the end of the plugger, it goes about 6 mils. A little bit of sealer on there, exactly how I do this. Sear off at the coronal part. Tap it down with your plugger, so we put a little like dimple in the top of the gutta-perca there with a fat plugger, with a big plugger. And then you're going to place your system B in again. You haven't put the heat on yet. You put it on cold. And then I turn the heat on as soon as I touch it. 2 to 3 seconds, push down, not touching the tooth. take your finger off the button to stop the heat after 2 to 3 seconds, press for 10 more, maintain that apical push so that we're preventing shrinkage of that apical material. And then after 10 seconds, separation burst, twist, hesitate, remove, and then we can backfill. So it's activate, deactivate, hesitate, remove. So it's bzzz, off, out it comes, done. If you're placing a post, you're done. If you want to backfill, I now get my, I don't use it, he uses a file here to place the sealer. I put my sealer directly onto the needle of the backfill unit. I place that in, I leave it 5 seconds for the temperatures to equalize, and then I'm going to inject and let it back me out of the root canal. You'll see on the clinical case I show shortly that I overfill the clinical case. I've got better since then. It's probably 15 years old, the clinical case. But I'm going to inject. It's easier to not put enough in and then go back again if you wish, add a little bit more. You can plug this, add a bit more, and we fill the canal. So it's a really nice way to go about this. One cone and a little bit with the backfill unit. And to me, this is modern technique. The Obturation has been around since the probably late 80s. The technique of the hot, 1967, that was using a flame and heat carriers. But the mechanized systems have been around for nearly 30 years now. So that is modern technique to me. So this is a clinical case of mine. It's an upper molar, 4 canals, a little bit bigger preps than I'd now do, but they're easier to fill when they're bigger. But this, as I say, is probably from 15 years ago or so. Just looking down all the canals here, you can see the beautiful way that the microscope leads us into the canals via the different colors of the vertical dentine and the axial dentine. I'm going to dry the canals. My final irrigant when I'm using the zinc oxide eugenol sealer is isopropyl alcohol. That dries the canals as it evaporates. You can see the little purple tip there. That's the capillary tips from Ultradent. And I fixed that into this little adapter for your suction here. You can see that pretty clearly on there how that works. I hardly ever need to use paper points when I'm using this. I use this to suck fluid out of the canals all the time. We use this every single case. Really, really useful. It's called a Tsutsui Tsunami, named after an endodontist in LA called Fred Tsutsui. And there's an Australian endodontist friend of mine called Tim Silbert, who's adapted it, make it a little bit more modern with the one at the bottom right-hand side. And that's now available only in the last few weeks on EIE's website. Very much worthwhile. Putting one of these on your cart, we've got 3 suctions on the cart, so we've got this permanently in place there, and I use this every single case. So we dry the canals, they look like this. I then have low pressure air only as well on my specific endo cart at about 5 psi, so I can blow air into the canals as well without any risk of emphysema, etc. And I blow that in there to help displace the final bits of the isopropyl alcohol to really desiccate stuff in there for the ZOE sealer. When I'm using bioceramics, they set in water, so my final irrigant is water, and I don't dry them as much. So these are my cones in place. There's maybe more sealer there than I now use. And if I've got joining canals like MB1 and MB2, I fill them both at the same time. That's my down pack. So this is looking down. It's difficult to tell with the plane of focus, but that's probably to 6 mils from the apex in both of those canals. Plug a little bit more, and then we're going to start the backfill procedure here. So this is the needle in there. As we backfill towards the orifice, and as I say, that's a little bit untidy now for how I obturate. You will see that I clean this up. I don't leave it like that. So I'm going back with my System B just to take off the excess. Then it's starting to look a little bit more tidy. And I'm going to use isopropyl alcohol again to remove any excess sealer. So then it looks like this, and then I grit blast it, and then I'm going to restore it. I always put the coronal restoration in myself. To me, that's coronal endodontics. It's part of the obturation. So I'm always obturating, filling the coronal part myself. I don't put temporary restorations in. So this had an amalgam Niar core placed in it. after we've cleaned it up like that. So it looks like this on the radiograph. So as I say, that was from probably 15 years ago or so, something like that. And then more recently, we've been a little bit more minimal with our preps, able to get lateral canals in the coronal part as well. So yeah, it's a nice technique to use. If you don't want to invest quite so much in the gadgetry, because maybe the elements unit and the Dentsply unit are a couple of £1,000, something like that. If you aren't doing a lot of endo, it's maybe not worthwhile spending that sort of money. So you then maybe want to consider the bioceramic systems. So I'm sorry I can't see the questions. I will have a look through them at the end. I can see something just popped up there, but I can't see them on the screen, unfortunately, at the moment. So we'll be reasonably quick through this. So bioceramics in obturation are maybe not as well researched as we think. Bioceramics have a big role in endodontics in maybe perforation repairs, in it's going to show you on this next slide, in endodontic surgery, in perf repairs, in pulp caps, in open APCs, and in pulpotomies as well. So MTA, the original bioceramic back in 1993, this was by Torabinejad. So again, it's been around a long time. A lot of research on MTA, good research, seals well, very biocompatible. Disadvantages to MTA are that it's pretty difficult to use. It's not cheap. It's technique sensitive. It's got a long setting time, and it can stain teeth as well. And it's almost impossible to remove. There are no solvents for this at all. So to fill a canal on its own is not recommended unless we're in specific retreatment cases. So I know there's a well-known Japanese retreat odontist called Teriyashi of the technique to remove broken instruments. He's filling all his canals with a wet slurry of MTA, but he's nearly always dealing with retreatment cases. Nobody else is going to try and treat those again. So if it's a last resort, it's maybe a material we can use. For a primary root canal treatment in general practice, we don't want to be using MTA. It's got certainly applications in perf repair, in pulpotomies, etc., in pulp caps, but in terms of primary endodontic filling material, it's not the material of choice. So the manufacturers then started to think about this and started to adapt the bioceramics a little bit, and they then started to make different materials. So as well as just the conventional material of MTA, 2007, a company called Bioceramics in Vancouver started to come out with materials that then went on to become the materials that we now see as ProRoot ISP as a sealer material. And there also are some putties and some paste that they can use as well as replacements for MTA. There's also biodentine as a material. Again, that's kind of outside of the scope of today's talk. Today's talk's purely obturation. Biodentine, really useful in a lot of applications in endodontics in terms of pulp capping, perf repairs, etc. But in terms of obturation, we're going to use either gutta perca and sealer or a bioceramic with gutta perca. So the left-hand side is what we're going to do with the bioceramic, because we aren't deforming our cone. We're not pushing on that cone. We're not heating the cone. We are merely applying the cone cold with that white sealer around it. The other side has had that thermocompacted, as I've shown with the System B. Why can we do this with the bioceramics? Well, they don't shrink, is the main reason why we can do this. They don't have that shrinkage, so they don't leave the voids that we had with conventional sealers. The downside to them is that they are insoluble. They shouldn't be used on their own without the central core of gutta perca, and we can block out the apical 2-3 millimeters purely with the sealer, which is going to make any retreatment really difficult. So we need to be a little bit wary of our case types here and make sure that we do a nice job. They are more difficult to retreat. We can certainly remove the central carrier of gutta perca, but there are no solvents that can remove this. Instrumentation will remove it to some degree, but then we're moving tooth away, which, as I talked about earlier, may not be a desirable thing. So be a little bit careful with making sure that we fit our cones correctly so we don't leave too much material in the apical, and we still want our gutta percha to get to it in that 1 mm working length. So this is kind of a summary of the materials that are out there. So we've got the bioceramic sealers, we've got the pastes, root repair materials in paste and in putty. And they all come from Innovative Bioceramics in Vancouver, and they're rebranded. So all the ones you see, iRoot SP, EndoSequence BC Sealer, Total Fill BC Sealer, they're all the same. It's the same material. They're just different brand names on the same material. So we're going to stick just to that top box today. And I'm going to show you how we use that clinically. Why do we use them? Well, there's less staining, increased resistance potentially of the root to fracture, but they are difficult to remove, especially, as I say, if your cone is short of length. And all the review papers about bioceramics in obturation all conclude with more research, clinical in vivo research and prospective outcome studies are needed, because as yet there's nothing to say they give a better outcome for the patient than classic gutta percha and sealer. So even though it says Total Fill BC Sealer here, you could substitute this for ProRoot SP, iRoot SP, etc. They're all the same product. I wouldn't use these with heat. They set really, really quickly with heat. So we don't need to heat them because, as you can see there, they don't shrink during setting and they demonstrate excellent physical properties. They're very biocompatible. They're set in the presence of water. So as I mentioned before, final irrigant is going to be sterile water. Suction out a little bit. I'm going to blow a little bit again, and then I'm going to inject this material into the canal. I will show some video from Gilberto de Bellion shortly of how that happens. But again, it's little tiny injection needles on here. Inject this into the canal. It's really quite funky to watch this down the microscope and see you inject into one canal and it come up out of the other canal when we have communications of the canals. And then we place our cone afterwards. So we place a single cone, sear that off at orifice level, and we're done. Forget about it. And don't play with it. Don't poke it afterwards, etc. You're done. Rinse that over the top. Put your final restorative over the top. Forget about it. It's quicker than one vertical. It's less steps. It's easier to do. It's probably more expensive in terms of cost of the sealer. But if you are only doing a handful of endos, it may be worthwhile considering that we don't then have to go out and buy all the kit to do all the other techniques with. And again, we've got matched gutta percha cones. We don't have to use the one that comes with the coated whatever. We can use any gutta percha cone. It's not an issue. But these are designed to match the prep shapes, etc. Match paper point if you want to use that. And again, if you want to be using in the heated guns, we can do that. But I don't see why you'd need a backfill with this, because you've not used a heated technique to make the space for the backfill to go there. But they brought that product to market in case somebody wants to use it that way. So the biocompatible, bone will grow onto them. They'll claim to glue to dentine and the bioceramic point. I don't think that's overly important. We've had a lot of people claiming to be able to bond to dentine in the apical part of root canals. I think maybe that's a bit of fantasy, and I don't think it's important either. They're radiopaque, and they set relatively quickly, and they don't shrink. That's the main thing for them. So that's why we can use them in a bigger volume than we can a conventional, be it ZOE sealer, be it an epoxy sealer, be it a calcium hydroxide sealer. And they're highly antibacterial. The pH is above 12 because they are actually releasing some calcium hydroxide as they set as well. So very antibacterial there. So this is how these are applied. So this is just injected into the root canal and it backs you out. So you can place this little nylon tip needle in there. You can see the bifurcation. It's going down both canals there. And then I personally just put a little tiny bit on my cone. I don't use the lentillo when I'm doing this, the spiral root filler. I don't think we need that as well. I think that could possibly lead to some overfilling. I put a little bit on my cone and I use my cone to help disperse this, but you can see there how this material flows really, really nicely. These 3D training teeth are superb for practicing these things on. Single cone, little bit of extra sealer. Place that down to working length that we've already measured. And then seal it off at orifice level and you're done as far as I'm concerned. So I use the System B part again. Seal that off. There's no vertical pressure here at all. That's it. We're filled. Nothing else. Cover that with resin, cover it with whatever. We don't need to plug like he's doing here. We just got to sear it off and fill over the top of it. So pretty straightforward. I'm going to keep the video running because he does some really nice stuff as he sections the tooth here. So you can see how this has flowed into the isthmus areas really, really nicely. That previously we'd only be able to do this with a warm vertical technique, much more technique sensitive. So as I say, this is a 3D resin tooth, direct replica from a micro CT scan of a real tooth. So nothing like the plastic blocks that we've all played with. These are just fantastic training teeth. And you can see there the isthmus tissue between there, zooms it up the scope, almost like the diagram we showed with the single core of gutta perca with the bioceramic sealer around the outside, and then just sealer in the isthmus tissue. But yes, it's a nice way to fill all this area. Okay, so we're getting near the end now. As I say, I'll try and have a look through the questions shortly. I will give you some contact details as well later on. So if there are questions, etc., you can drop me an email later, and I'm very happy to go ahead and answer everything. Now, what I don't want to do is start fiddling with my computer and you lose all the feed that you're getting out here. So this is just showing again the type of fills that we get in vitro work with a single core in the middle, with a stable sealer around there that isn't going to be resorbing, isn't going to be shrinking over time. So I think this is interesting. I'm not ready to move to this in its entirety at the moment, even though, as I said, the material's been around since 2007. There isn't enough data for me yet to move to this. I'm a bit of a fossil in moving along and changing things. Where it is going to be useful, I think, is in the minimal preparation shapes where we know we're not going to get heat into the apical part and we really are only doing single cones. I think this is going to be interesting there, but we do need to be wary of retreatability later. So this is one of the first cases I did with it, and this case came to me with, as you can see, it's the lower 6 that we're treating here, and the referring dentist had been into the tooth, and his description to me was, I found 4 canals. And that was what my pre-op looked like. So there's been some work done there. They're pretty narrow canals, yeah? And this was the appearance that I got when I dropped into the pulp chamber there. So I hadn't really found 4 canals. They'd cut 4 holes in the top of the root canal chamber and left all the roof of the chamber there. So maybe it was ahead of its time in what we were seeing advertised as the ninja access now and the truss preparation. But I corrected that and removed it, got all the necrotic tissue out of there, and then went ahead and cleaned it all out, bigger shapes back in those days, and fill this with single cones. And you can see we're getting to the apex nicely there. Restored the coronal, off-angle view to show that the nice fill there. So it's a simple system, relatively straightforward to use. And this is this afternoon's case. So it's nearly 4 months since we've done any endo. And this was one I chose to use bioceramic on today, purely for ease of use, and it had been accessed again at a UDC somewhere over the lockdown period. You can see the image top right, you can just about make out a glass ionomer, tiny pinprick where the access had been made. You've got an old amalgam in it, a relatively new resin. I leave those restorations whilst I'm working to hold my irrigant in place, so that they work to help me have a reservoir of hypochlorite whilst I'm working. Then I remove all the restoration before doing the restorative. There's a post sunk in there as well, which is a fiber post, which you don't really see on the radiograph, but it's there. And then that guy's going to go ahead and get a crown done there. He's got a lot of other dental needs as well. He's a guy who I saw first a couple of years ago for a lower tooth. He's got issues with other teeth which he needs to get sorted out, but I don't think it's his main priority was the pain he'd had with this one. So we've tidied him over till he goes ahead and gets his crown. And then I always like to finish with this one. We haven't talked about preparation and access today very much, but I'm a stickler for rubber dams, so we always like to put rubber dam on the teeth no matter where they are. Did take working lengths here, as you can see. Obturate. And then to be sure that we're not going to break the tooth, put a crown on there. That's just my sense of humor at the end of that. That's not real, but it's not Photoshop either. What's happened here is the tooth was treated outside of the jaw. It's a mandible, and the tooth superimposed over a mandible. It's an extracted tooth superimposed over a mandible to look like that. So final slide are some links for people. I talked earlier about where you could find the papers from Schilder and where there's a heck of a lot of papers. Now PubMed is kind of opening up and you can get more papers on there. But a colleague of mine called Rob Kaufman over in Winnipeg runs the website endoexperience.com. It is absolutely full of literature, of articles about endo, and it's got all of Schilder's original work. Rob actually trained under Schilder at Boston University, and I've learned an awful lot from him over the last 20 years that I've known him about obturation. I encourage you to look at the British Endodontic Society. I've got to plug them, obviously, I'm a former council member of the society. TDO for Endo is my software that I use, and the Endodontic Academy is a really high-powered organisation for endodontic experts from around the world. We were supposed to be meeting last weekend in Scottsdale, Arizona, but obviously that was postponed for a year. But an organisation I'm very proud to be a member of. And my email is at the top there. So if people want to email me, etc., and have any questions, I'm going to see if I can find the Q's and A's now. Here we go. Don't ZOE sealers resorb like tubular seal? They resorb, but outside of the canal, inside of the canal a little bit. Do we see treatment failure in the future? Well, there are hundreds of thousands of millions probably of teeth with ZOE sealers that haven't failed in the future. Right, somebody's asked about a perio-endo relation. I haven't got time to talk about perio-endo. It's a big topic of mine. I don't think there is such a thing as a true perio-endo lesion. It's either primary perio or it's primary endo, and we need to diagnose properly. So let me go through the other. Where do we buy isopropyl alcohol from? You can buy it from eBay, or you can buy it from QED, the dental suppliers. Can you, if you have to ask me, I know this is going to sound a strange answer, can you please briefly explain how you fill the whole canal with MTA? If you have to ask me that question, you shouldn't be doing it. Does that make sense? With bioceramic sealers, are they heat sensitive to system B? Yes, they are, so I wouldn't recommend heating them. They set up really, really quickly, so they're designed to be used with a cold technique. If you really want to find out about how to fill a canal with MTA, you need to start to have a look and do that, but you really need to have a microscope for that and a lot of experience. Application of the sealer onto the backfill tip, always had an occasional void. Yeah, we still get voids, they're not clinically significant. Do they concern me? Well, they don't look brilliant when I send it back to the referring dentist, but I don't often go back in and correct them. And then if there's radiographic changes seen like periapical radiolucency on a root treated tooth, patient has no concerns, what's the most appropriate time period to record? It's a great question, and one which we have been talking about in various forums that I'm a member of and at conferences for probably 15 years. Impossible to answer really quickly. I'm not copping out, but it depends. If the patient has no concerns and no future dentistry is going on it, I'd be looking at it every 5 years or so. If we're maybe going to put future dentistry on it, or if the patient's going to be going away to Antarctica for 6 months and hasn't got access to dental treatment, then I might go in and treat it. It really does depend. We have some patients who are submariners. So they're going to be going away in the Navy on a submarine, nuclear submarine, for 6 months plus. If they have to surface that submarine because somebody's got a problem with the tooth that you said might be all right, they aren't going to be too pleased. So it's individual. It's individual. If your patient is happy, and it does boil down to the patient, if a patient says to me, I really want you to treat it, doctor, because we've got a thing, then I'll do that. But most patients are happy to leave things like that because they aren't giving them problems. What do you use to remove old GP? Maybe we can do that in another webinar, because that's going to take me a long time to describe that. There's lots of different methods to remove old GP. And again, I think retreatment to me is something that needs to be done with a microscope and with quite a bit of knowledge on there. It's something that isn't something I think a general practitioner should be looking to do. So it's not something I can answer just in 2 minutes or so. Asymptomatic tooth with widening periapical area. Do you do RCT or not when having a crown? So if it's getting bigger, it says widening, not widened. So if it's getting bigger and it's changing, which indicates active disease, yes, I would treat that. And yes, I would wait until I see resolution of the finding on the radiograph before I go ahead and recommend a crown to the referring dentist. If it hasn't changed, and if I've got historical radiographs that I can show going back with no change over 5-10 years or so, then I have the conversation with the patient and with the referring dentist and ask how they feel about leaving that. And I can answer that from a personal point of view because I've just had a crown made. It was fitted last week, and I have a periradicular radiolucency on my root-treated upper right 6. That has been there for 15 years. There's a missed NB2. I haven't had it retreated on myself. If I do need it retreating in the future, it's dead easy. We can just cut through the crown, do the retreatment. But at the moment, totally symptom-free. I'm happy to leave that on my own tooth. And I've also seen Professor Paul Wesselink from Amsterdam. He gives a presentation called, Do We Treat This Lesion or Not? And one of the teeth he shows is his own tooth 30 years later with a widening, but exactly the same as it was 30 years before. The tooth has survived for that long. What concerns me sometimes is we go in and we try to make things better just on the x-ray picture, but we actually make things worse by doing what we do. So it is very much down to a discussion with the patient and a discussion with the referring dentist. If the referring dentist says to me, look, Bill, I really want you to go in and treat that tooth because of this lesion, because it might do this, and I'm going to put £5,000 worth of fixed endodontics on it, of course I can do that. But if I say, well, I'll tell you what, doctor, whatever, I think there may be a problem if I do that, in that I may destroy tooth. Maybe you could leave it like it is, put a temporary on there, semi-permanent restoration, leave it 6 months, see what happens. If it's symptom-free, then go ahead and carry on. I'm concerned about restorability, and I'm concerned about keeping teeth as long as possible. And often, us drilling teeth is not the best thing to do. See if I've got any more questions to go through. How long do you wait? There is no specific answer to that. Which obturation technique should a beginner prefer? Very difficult to answer that one. I like to practice before I go ahead on patients. So I'm going to practice on plastic blocks. I'm going to practice on training teeth. I think for difficult to answer because I'm going to do the training first. Bioceramics are a lot easier to use than warm vertical. So maybe use bioceramic, and then if you do get into endo, you're going to have done lots of warm vertical cases anyway in your training. So that may be the answer. Elements versus Dentsply cordless, which one would you recommend and why? Whichever's cheapest. Whichever's cheapest. They're both going to do a really good job. It makes no difference really as to which unit it is. I think we've got them all now. I'm not seeing any that I've left open there now. Oh, hold on, we've got a totally previous history of trauma, completely sclerosed canal, asymptomatic tooth, no pathology, no response to vitality testing, needs a crown, what warning to give, and why did it need a crown? Would be my first question. Would it, I mean, the risk of making a real mess of the tooth by going in and trying to find a canal, if you don't have some of the things that we have now, in cases like that, cone beam CT is really, really useful. Yeah, that's a question for an endodontist. It's not, you need an endodontist to be looking at that. There are guided systems out there now, dynamic guided navigation to enable us to get into canals properly. But again, I would question, why does it need a crown if maybe there's a fracture, etc. The really clever people can nearly always find a root canal. The really clever people can nearly always find a root canal. So it's discolored, internal bleaching. You can internal bleach without doing the endo. Again, the clever people are doing this. Clever people have done this for a long time. So you can cut an access cavity, put some of your bleaching agent of choice in there and bleach it internally. Again, we're cutting less tooth away than doing a crown prep. So we've got, I haven't got them on the presentation service, but we've got cases that we've done that on where we haven't done the endo. We've just cut an access to be able to do the bleach, doing in and out, walk-in bleach type technique, works really, really well. So I think we're nothing more that I can see. If you do want me to talk about anything else at any other time, let the people at Tipton Training know. I've got tons and tons of presentations about lots of interesting things on endo. Today was maybe just a taster. I'd normally maybe spend a day doing this, including the hands-ons, etc. So it's really quite difficult for me to do this well in an hour, particularly when I can't see who I'm talking to, etc. as well. It's a strange experience, but thank you very much for your interest. Thank you for the questions. They've been good questions, and enjoy the rest of your evening. Cheers.